So I want to welcome the new R2s to their first research grand rounds. We look forward to working with you over the next 4 years as we try to present you once a month at this time with some a menu of things that will enhance your research careers. The typical format is that we will first present a paper from a UW faculty member that has been published in the last few months. This is so that you get to know your attendings, not only for their clinical work and as teachers, but also so that you can get to know the work that they are publishing that you may otherwise not have seen. Then typically we will have a presentation, a research presentation, ideally a partnership between a basic scientist and a clinician. And today is no exception because our basic scientist today is Katy Kollitz Jeapragasan. That name may be familiar to you because she is indeed related to Ned. And Katy partnered with Dr. Wong, and together they have explored the issue of tendon healing enhanced by, or not enhanced, by PRP. And so you'll hear from Katy a little later this morning. And then the third section is that we'll present you with a series of research building blocks that we think will help you in putting together a solid foundation for your research careers. And what better place to start than getting money to support the research that you want to do? And that's where we're going to start today. I also have got some forms that I can't let the R2s go without getting these forms signed, else Teresa will send me to the doghouse. So I've just put these on the front table, and I would like you to come and sign these before you leave today. And I'll explain to you what this is when we get to the relevant section. So let me start right in with the literature review. And the paper I've chosen today came out in Foot and Ankle in March online. And it's a paper from the Foot and Ankle Trauma Group, Brusvati, Kramer, and Benershki, who have a paper entitled Medial Plantar Wounds Associated with Calcaneal Fractures. Some of you probably know that Dr. Benershki has a international regard for his work in calcaneal fractures and other foot trauma. And he has published in the past, and by the way, I have a little congratulations first, 2 of them, because as I review the literature for this meeting, I come up with other things that have been done, and congratulations to Jacques and Amy and the collaborators, and Mike Lee and Jens's guidance paper, which I think is going to become a real standard paper in the literature, showing outcomes in relation to socioeconomic status. Another congratulations to Jacques. Jacques, you had an activity here today? Mm-hmm. Yes. After his successes as an MC on Friday. Good job, by the way, at the meeting, at the banquet. Another paper. Jacques, tell us just a little bit about this one.
Well, I'm the author.
Okay, enough said. He turned up and read the manuscript. But it was a very interesting attempt from Jacques to, probably when he came to UW, he didn't know what ESCT histone was, but now he does, and he published on it. So good job. So let's get into this paper. Over the years, Dr. Benershki has published a number of papers on calcaneal fractures and on factors affecting outcome. But in this particular paper, they looked at a subclass of fractures that have a medial plantar wound. And the purpose was to evaluate soft tissue healing and complications in these open calcaneal fractures that have a plantar medial wound. Now, one of the reasons I'm showing you this paper, in addition to that it's current and possible, is that you could do a study like this today without having an IRB, as I will show you later. This study exactly fits our retrospective IRB omnibus that we have. So this is one of my as I like to call them, 10-click IRBs, that you could do a 10-click IRB this morning and have a study like this by Friday, send it out to the journal on Monday. Not quite, but that's possible. So they looked through, retrospectively, through the trauma database at 1,241 calcaneal fractures since January 2000 up to April 2008. That's 103 calcaneal fractures a year, and 155 of these were open, and there were only 12 wounds that met this particular inclusion criteria. So these are not very frequent fractures. So have any of you seen any of these during your time here? Open fracture with a medial plantar wound. So 12 out of 1,241. These were put through the routine treatment plan for these wounds. There was plain films bilaterally. There was a CT of the involved limb, systemic antibiotics, tetanus prophylaxis, and a splint. A two-stage approach to treatment. They were first debrided, irrigated, a temporary fixation with a percutaneous pinning and an exoskeletal device. The goal was to restore calcaneal height and to try and decrease the tension in the soft tissues. And the aftercare was a plantar splint, IV antibiotics for 24 to 72 hours, and gentamicin in the type 2 and 3 wounds. So then the definitive reconstruction, usually about 30 days later, was an open reduction internal fixation when the soft tissue swelling had subsided, lateral approach with conventional calcaneal implants, additional implants as needed, and all of the temporary hardware was removed. Post-op care was standard, nothing particularly notable there. The patients were evaluated on at least 2 post-operative occasions, and the definition of healing was when the plantar medial wound had completely re-epithelialized and didn't require any dressing changes. So here are the results. On the Castillo classification, there were 3 type 1, 4 type 2, and 5 type 3. The plantar fascia was almost universally disrupted. There was a change in sensation in about half the cases on the medial aspect of the foot. The medial branch, plantar branch of the tibial nerve had become involved in the initial debridement in 2 cases. Surprisingly, no vascular injuries, and here's the real bottom line of this paper. At a 40-month follow-up, the mean time to heal was 22.7 months. So it takes a long time for these wounds to heal. The 5 of them developed osteomyelitis requiring debridement and 6 weeks of IV antibiotics, and you can see that they were not particularly predisposed to a particular class. 2 of the patients had split thickness skin grafts. 1 of 12 patients required a gracilis flap, and a quarter of the patients went on to non-union. So the discussion for this paper is that the authors felt that the grading used, the Castillo classification, wasn't particularly useful because it doesn't highlight the soft tissue involvement of these particular wounds, and that the Schöner grades are likely to be more useful and more predictive. And lastly, that the patients with this type of injury should be informed that this injury has a lot of complications, takes a long time to heal, has high infection rates, and has a higher potential for amputation than other high wounds. So it's not a particularly promising outcome for patients with this particular injury. Now, some of the limitations of a study like this, of course, are typical to a retrospective study. You don't know exactly the homogeneity of the group. Some of these, for example, some of these wounds were backed and some weren't. So there's a lot of open questions. You may have others. Any questions about or comments about this? Kenny?
But I don't know when the project started to be interesting, but it's like a pretty much direct rebuttal to a paper out of San Antonio from last November where they, with these same injuries, used that medial wound, opened it, and then percutaneously used only percutaneous fixation instead of still using the big lateral wound, which has potentially higher risk for soft tissue troubles. And I think there will be more to come in this area, and we'll relate to one of our grand rounds next spring on percutaneous versus open reduction internal fixation for calcaneus fractures by Dr. Bernurshka and Dr. Sanderson. So anyway, the article is in JOT from November of last year by Beltran and Collins about their approach to these injuries.
And they don't refer to this because the two were running parallel through the
I
review
think they're
process.
by running parallel.
Yeah. Surprising there wasn't a letter from the editor with this one, actually.
Yeah, different journal.
All right.
Same.
So I want to turn now to the main event, and Katy is a medical student at Duke who has taken full advantage of a remarkable program at Duke where medical students have a whole third year for research, and they can go anywhere that will take them. And quite at random, Katy chose to come to the University of Washington, and she, I have to say, has been a remarkable example of what you can do if you're motivated and if you're willing to take the most of your opportunities. What you're going to hear today is just a small fraction of the research that she's done during this year. She's done many things, published many abstracts, got many papers that are in process, and she's devoted most of her time, however, to the study that you'll hear today, which she and Dr. Wang have done. So, Katy, please come and give us your presentation. Is this the one you wanted?
Yep. Okay. Thank you so much. Thank you very much for that kind introduction, and thanks to you guys for having me today. So I'm a fourth-year medical student at Duke, and this is my primary research project, a radic flexor tendon model for a PRP for flexor tendon repair. After I go over the research a little bit, I'm just going to talk about a few lessons learned in doing animal research, and then I'm going to have Aaron come up and talk a little bit about doing biomechanics up in Dr. Kavanaugh's lab. So Zone 2 remains a challenge in hand surgery. It runs from the metacarpal heads up into the base of the middle phalanx, and you can see that that's the zone where both FDS and FDP run through a series of fibroosseous canals, the Foley system. So rupture in this area and repair is difficult. Any excess surgical knots or scarring can lead to a poor functional outcome, so stiffness is not uncommon after a repair here. There's been some work that shows that early physical therapy and range of motion activities can improve adhesion formation and range of motion, but unfortunately the tendon actually doesn't gain tensile strength above the sutures that you use to repair the tendon until about 3 weeks after surgery. So that early activity and range of motion also puts the repair at risk. And right now we have about a 6 or 7% rupture rate. Reoperation for stiffness is not uncommon. So given the challenges in this area, there are a lot of biologic adjuvants to healing that have been investigated. So I want to point out a couple. Platelet-derived growth factor, PDGF at the top, is associated with better tendon gliding. This has been done in an in vivo model. This might be because of its influence on fibronectin and hyaluronic acid. Another one to think about is transforming growth factor beta. So TGF-beta is associated with increased collagen deposition, but it's also associated with increased adhesion formation. So a lot of the work on TGF-beta is actually on suppressing its activities so that you get a better functional outcome. Other ones that are interesting, basic fibroblast growth factor, insulin-like growth factor, and of course VEGF. So all of these are actually found in platelet-rich plasma, which has gotten a lot of attention recently because a lot of professional athletes like Kobe Bryant, like Tiger Woods, and even celebrities like Kim Kardashian have had platelet-rich plasma injections. So here, these growth factors that we just talked about are found in platelets and some of them in the serum. Platelet-rich plasma is an attractive source of the growth factors because they're autologous, and so they're considered pretty safe. They're also pretty inexpensive, especially compared to a bioengineered growth factor that you would have to get through, transforming bacteria. And The idea is really appealing to patients, so they like the idea that they're using something that's found within their own body to help them heal. We do offer platelet-rich plasma injections here at the University of Washington. Injections are ultrasound guided. They're $800. You can get them at Hall Health. Platelet-rich plasma protocols frequently do call for multiple injections, and the market for PRP is pretty small currently, $45 million in 2009, but projected to nearly triple by 2016 to $120 million. Common uses for platelet-rich plasma are rotator cuff repair, Achilles tendonitis, and also lateral epicondylitis. Many of the studies that show a favorable effect of platelet-rich plasma are actually level 3 or level 4 evidence, so we don't have a lot of really strong evidence, but in lateral epicondylitis we have some level 1 studies that do show a benefit. So here I'm showing you one of the more commonly cited studies in support of PRP. You can see they did a randomized control trial, double-blinded, PRP versus glucocorticoid. And PRP was associated with significantly increased DASH scores after 1 year. So given that PRP contains all of these growth factors which do have a benefit to flexor tendon repair, we wanted to see if we could find any kind of benefit in zone 2. So we hypothesized that we would increase tensile strength and that we would decrease scarring, and that this would be caused by the stimulatory effect on collagen deposition, also anti-inflammatory effects of PRP. So let's go over the methods. We took 30 New Zealand white rabbits and we divided them into 2 groups. We incised and repaired their tendons, and half of them we treated with PRP, and the other half just had a standard repair. We analyzed those tendons at 3 different time points, so 2 weeks, 4 weeks, and 8 weeks postoperatively. We actually operated on 2 toes in each rabbit, so half of the toes went for biomechanical analysis, or the first toe did, and then the second toe from the same rabbit went for histology. The PRP was prepared intraoperatively, so it's autologous for each rabbit. We took a blood sample and spun it for 5 minutes at 1300 RPM. So here's a picture of the product that we used. In the surgery, we isolated the FDP tendon. We incised it, repaired it immediately using a modified Kessler stitch with figure of 8 over the top. So we had a 4-strand repair. Rabbits were immobilized for 2 weeks postoperatively, and then they were allowed to roam freely in their cages. Again, they were euthanized at 2 weeks, 4 weeks, or 8 weeks, depending on their group. For biomechanical analysis, the first step we took was to leave the toe and the tendon intact. We mounted the toe here on a testing jig and attached a weight to the distal end of the toe in order to achieve full extension. We attached a weight to the proximal end of the tendon to cause flexion, and then we measured the excursion of the tendon from the A1 pulley. We also looked at the angular range of motion using digital photographs to measure the MCP and the PIP flexion. Next, we dissected the tendons free from the toe and from the pulley system and mounted it here on the robot, which is found in Dr. Kavanagh's lab on the 10th floor. We distracted the tendons at 0.2 millimeters per second. We had an inline mode cell, and we recorded the maximum force that the tendon withstood until it broke. So looking at histology, we used 3 different stains. We've got H&E here on the left. We have trichrome, which is excellent for looking at collagen here in the middle. And then piper-serious red is a little bit difficult to see here on the right. So looking at this image, we've got P1 here, about a purple head. You can see both FDP and FDS here under the A1 pulley. And then we're here at Camper's chiasm, so here's the scar tissue here, and then we see healthy tendon going up to continue to the distal phalanx. Piper-serious red deserves a little bit of explanation. It's not a common stain, but it has a property where when it's adhered to collagen, it becomes birefringent under polarized light. So you can actually analyze the maturity of the collagen by looking at the color. So very thick fibrils appear red or yellow, and thin, immature fibers are either blue or green. So we performed cell counts at 630x magnification using our H&E stains. We did 5 high-powered fields per specimen. Here we've got a closer image of that same tendon that I just showed you. We've got bone down here, scar in the middle, and healthy tendon on either side. So in order to analyze the collagen content, we separated out the colors of trichrome, which are red, green, and blue, and we looked at blue only because that represents collagen and trichrome staining. You can see that the scar area, not all of the blue there actually represents collagen, which would be blue here. So we used a thresholding technique to identify the intensity of blue that truly represents collagen, and then we were able to outline the area of the scar and calculate the percentage which is occupied by collagen. We used a really similar technique with Picker Series Red. So we've got healthy tendon in this nice orange-yellow color here, and continuing on here, and the scar tissue area here in the middle. So we separated out the colors into red, green, and blue, and here's red that we analyzed, represented by white. Again, we thresholded this, and we calculated the percentage area occupied by mature, thicker fibrils. So what did we find? Let's talk first about ultimate strength. So here we took 5 contralateral toes and we did the repair and tested it on the very same day so that we can find out what's the strength of the repair that we're using. You can see that all the tendons healed, so at 8 weeks we have a significant increase in tensile strength in both the PRP groups and the control groups. But looking at at each time point and comparing the strength of the tendons which were treated with PRP to the control tendons, there's not a significant difference at any time point. We were interested, though, to see this trend that at 2 weeks, there was actually a trend towards decreased tensile strength, so that's something we want to explore. Looking at excursion, the day 0 represents the effect that the bulk of the repair has on our tendon. And you can see, again, there's no significant difference between tendons which were treated with PRP and tendons which were repaired in the standard fashion. There's a small trend at 8 weeks towards increased excursion. And we really see similar results here with range of motion. So this is the angular range of motion, MCP and PRP added together. No significant difference when we treated with PRP versus just a standard repair. But we did see that trend here at 2 weeks and 8 weeks where there's a slight increase in the range of motion when we used PRP. So looking at histology, over time, both the control group and the PRP group had a reduction in cell counts. So this was significant in both groups, but it was more pronounced for PRP. So at 4 weeks, there were fewer cells in the PRP group as compared to 2 weeks. For collagen content, we saw that the control groups increased their collagen content by more than the PRP groups did. And this approached significance, so our P was 0.06. We have a similar trend here for maturity of collagen. So in the control group, the maturity or the percentage of mature collagen increased significantly. In the PRP group, we really couldn't detect a significant difference between a 2-week and a 4-week tendon in terms of the maturity of the collagen. So what does this mean? Looking first at ultimate breaking strength, I want to remind you that there's not a detectable difference between PRP treated tendons and control tendons at any of the time points. But again, we were really interested to see that at 2 weeks there was a trend towards a weaker tendon when we treated it with PRP. Looking at the literature, here's another study on PRP where they did find a significant increase in tensile strength at 2 weeks when they applied PRP. This effect disappeared at 3 weeks. And that's actually the opposite of what we found. And I think what it comes down to is this is pretty representative of what you see in the literature of PRP. So it's difficult to draw trends that are consistent throughout studies. Looking at our range of motion results, we did see that trend towards an increased range of motion when we used PRP at both 2 weeks and 8 weeks. And we thought maybe this was because there was also a trend towards reduced collagen and reduced collagen maturity when we used PRP. So perhaps when we used the PRP, there was a little bit less collagen being deposited as compared to controls, and this resulted in also fewer adhesion formations. This also might be connected to the reduced cell counts when we used PRP. So maybe those the reduction in cells could represent tenocytes laying down a little bit less collagen, causing fewer adhesions and increased range of motion. Looking at the literature, here's a study done from Spain on the sheath Achilles tendon. They had the same effect where in both the control and the PRP groups, their cell counts were reduced, and it was more pronounced in the PRP treated tendon. So that's what we also found. And one thing to think about is that this may be due to the activity of TGF-beta. So TGF-beta is an important mediator of fibrosis. It's involved in a lot of fibrotic diseases and also involved in abnormal scarring in humans. There have been studies that show that TGF-beta will significantly increase collagen deposition. But at the same time, cell counts are reduced when it's applied. So here's an in vitro study showing a dose-dependent reduction in cell counts. As TGF-beta concentration rises, there's a greater decrease in the number of cells in each sample. So this wasn't always statistically significant, but this was a trend which was consistent throughout all of the experiments that this group did. Platelet-rich plasma does affect the expression of TGF-beta. So you can see that in the first couple of weeks of healing, PRP will increase TGF-beta expression as compared to a biologic or a physiologic healing model. And then in the next 2 weeks, that TGF-beta is reduced by PRP as compared to sort of your physiologic levels. So that's one area that we'd really like to explore a little bit further. Other things that are important to think about when you look at PRP, your preparation method will cause a very different content of growth factors and other substances in your preparation. So leukocyte concentration is really important to look at when you look at PRP. A high concentration of leukocytes will produce a high concentration of TNF-alpha and IL-1 beta, and those are both pro-inflammatory cytokines. So your inflammatory profile can be manipulated by the content of leukocytes. Other growth factors are also affected depending on how you prepare your PRP. The delivery method is important to think about as well. So you can use a fibrin or a heparin matrix to create a time release effect. Meanwhile, some investigators are actually activating their platelets to release all of the growth factors at once. So it's important to think about how is this delivered. You can get a similar effect actually by doing multiple injections over time versus a single injection. So we used one injection, one preparation of PRP, and it's important to remember that because of this, because of the heterogeneity of preparations, it's difficult for us to draw conclusions that are sort of broader than the study at hand. And in fact, that's actually the thought that I want to leave you with, is that PRP is not one substance, it's not one drug. This is different across preparations. You're basically delivering a large mixture of growth factors, and each of them has an effect on the tendon, and they all interact with each other. So depending on what you deliver, you're going to tip the balance between anabolism and catabolism in that healing tendon. We really need to get a better understanding of each of these growth factors, and then also how they interact with each other. And once we have that, I think we may be able to manipulate the content of our PRP in order to achieve the outcome that we're looking for. So, I think PRP is still a viable, inexpensive source of growth factors, but we need a better understanding. There's a lot more research that needs to be done and questions that need to be answered before we can really find this to be useful. So, any questions?
Where did you get your PRP protocol?
So the protocol is it's a commercial kit, and we follow the recommendations by the manufacturer.
So has that been standardized in the literature, or is that?
No, and that's one of the things that's difficult when you look at studies across the literature, is that everybody has their own sort of preparation protocol. Some people are, spitting it multiple times, taking different layers. So this was one that's commercially available, being used currently either in the operating room or in the clinic.
Go home bio. I would say it seems like this is a lot of work, to test one preparation type with one kind of protocol. And it would seem almost like to do what you think needs to be done, it makes a lot of sense to me. You almost need like a high throughput, like where you can test strains in vivo, without having to do some of these other things. Or are other people using models like that, or are they still trying to figure out a way to be able to test some of these strain things without, every single time having to repair and wait these different weeks and do all that? That's a lot of work to do a lot of work.
Yeah, you're absolutely right. So there are a couple of different things that are happening. You can harvest tendons and grow them in culture, and then try and break them. So you can, especially if you only cause a partial defect, then you don't have to worry too much about actually repairing it and let it heal on its own. So Smaller animals like mice, rats, using their Achilles tendon is certainly viable. And again, you can do the repair, you can cause a partial defect. I do think that it's different to completely cut it, and there is some evidence that the tendon type is important. So an intrasynovial flexor tendon behaves differently than an Achilles tendon, for example. But there's still some similarities that you can draw conclusions across.
Was there any effort to kind of measure concentrations of the various factors that were present in the PRP solution, or?
In our study?
Mm-hmm.
So we did do some cell counts just to make sure that we were reducing RBCs and increasing platelets. And we did achieve that, but no, not in this study. We didn't look at the concentrations of the various growth factors.
When you apply tension to the tendon, where exactly was the rupture after the repair?
So in 2 weeks and 4 weeks, the rupture was in the scar, so mid-substance. By 8 weeks, the tendon actually had gained enough tensile strength that the defect we created by suturing the tendon to the robot actually was enough that it broke right at that defect. So that's actually a challenge in testing tendons, and I've talked about this with a couple of other attendees who have done this. It's a tough to break an intact tendon right in the mid-substance.
Nice presentation, thanks. What was your hypothesis going in?
So we hypothesized that there would be a benefit. We thought, given that there's all these growth factors in the platelets themselves, that delivering them is going to increase the tendon strength. There's also some evidence that PRP can be anti-inflammatory, and we thought, okay, so maybe that's going to reduce our infusion formation. So that's what we thought. So just going to say a few words about animal research. The first step that we took was we wanted to get some cadaveric animal tissue in order to work out our protocols and make sure that they were repeatable. I actually bought rabbit feet from a farmer. Obviously food sources are not regulated by our research institute, and so it's okay to do that kind of thing. So if the animal that you're working on is something that is farmed, that's an excellent source. The other thing that I only learned later is that we're not the only group that's working on rabbits, and you can get spare parts from other researchers once they're rabbits or whatever animal you're working on, mice, rats, whatever. Once they reach an endpoint, frequently only a small part of the animal is harvested, and you can reuse that. So that's just one thing to keep in mind. The other thing I want to mention is that there are learning effects involved in everything that you do. It's important to randomize your conditions so that as you get better and better at your procedures, you aren't affecting only one group. So fortunately, our rabbits were pretty randomly distributed, but it's important to kind of take that into consideration. When you're looking at a protocol with the Institutional Animal Care and Use Committee, one piece of advice is to anticipate that you're going to have to make changes. So we did have some difficulties with the postoperative immobilization protocol. Animals, they want to chew on their bandages, they don't like it, so it took us a few tries to get something that was actually going to appropriately immobilize them. So that's important to give yourself a little bit of wiggle room when you can. We also did need to change our protocol for blood draws, so it's important to think about that when you're writing for something like this, that you may fail your first attempt at getting blood, and you need to give yourself permission to get a second attempt or to use a different vein, for example. A similar story with numbers. So, things happen in your research. Your animals might die before their endpoint, for example. None of ours did, but they could, and so it's important to write preemptively that you may need to increase your numbers for several reasons and kind of list those out. Otherwise, you do need to wait to get approval for your protocol change, and that can kind of delay your research. And when you have such a short time frame like you guys do, it's nice to avoid that if you can. There's also a method, an iterative power analysis method for giving yourself kind of an open end as to how many animals you're going to need, where basically you have a set number of animals per group. You look at your data. If you achieve statistical significance, you don't add any more, but if you didn't, you add a predetermined number. So there's a lot of information about this method on the IACUC website. It's an excellent method because it gets you scientifically valid results without having to use excessive numbers. And then finally, vet services will look at your protocol before you submit it, and they're actually a separate group from the IACUC, but they can give you advice, is what you want to do practical. They can also tell you just practical things like dosing for, ketamine for a rabbit. I didn't know exactly what to give them, so that's a great service that they offer. Finally, for training, because you guys are already in surgical training, you don't have to do any of the hands-on courses that would otherwise be required of you if you want to do surgery on animals. So we had to do an online module, and then we had an in-person training on how to handle a rabbit, so just how to pick it up and stuff like that. But otherwise, the training was very simple for us. If you're going to administer anesthesia, there is training associated with that. But as your animals get larger, it may be worthwhile to consider that Vet Services would deliver that for you, and you can get up and running with your project in a quicker fashion. So those are kind of the lessons that I learned with animal research. Happy to talk to anybody if you've got a project going on and you have some questions that maybe I can help with. But for now, I'm going to turn it over to Erin, and she's going to talk a little bit about biomechanics.
Thanks, Katie. Yeah, so I just wanted to put a face to the robot. I'm Erin Parsons. I work up on the 10th floor of the BD Tower, and I do a lot of biomechanics stuff. So for Katie's project, I just worked on the tensile strength of the tendon testing, but most of what I do is cadaveric knee testing for biomechanics, as you can see in the picture. So I just wanted to talk about, collaborating with other people and other groups. I specifically work with a bunch of different people. I work with some of the residents here. I work with people at the ME building, people at the BioB building, people at the electrical engineering building over at UW. So I think collaboration is definitely an important thing in research as a whole. As you can see, we get a lot more done, more expertise, more knowledge, and more people to cover a broad range of topics. And for me specifically, and working with me, if somebody has a project about biomechanics and wants to, come talk to me, or I work for Peter directly, so talk to Peter as well. But yeah, we do a lot of cool stuff up there. We have a lot of fun toys and instruments to play with. We have pressure sensors and just general passive motion markers and all sorts of stuff. And I work directly across from the arthroscopy lab up on the 10th floor, so it makes kind of a nice leeway to go back and forth and, dry scoping and everything like that. Yeah, that's me. So I think I'll turn it over to Katie again.
I just want to say thank you to both Dr. Wong and Dr. Kavanaugh. They've been super helpful to me this year, so I really appreciate you guys taking me on as a research assistant. Also want to say thanks to Erin, who were instrumental to the project. I want to say thanks to Trixie, if she's still here. She has been so helpful to me this year. And I was in clinic with a lot of the residents and fellows, and I just want to say thank you for teaching me so much. I really appreciate it, and I appreciate the department being willing to host me. So thank you guys.
Thank you, Katie. And Katie's on her way out now to do her clinical rotations, and so I have a little gift for her here. I think some of you know that I misspend my free time by looking for birds, and this is a photograph of an eagle taking off. And Katie's kind of taking off as a clinician scientist, so I thought that'd be appropriate for you. Thank you, Katie. All right, we have a few minutes left to cover some of the other topics, so let me ask you to sit tight while we talk about two other things. And first, is giving money away, which is really a good topic, and it's something that Teresa and I just love to do. And so I want you to give me the opportunity to give you some money this year by giving me a decent proposal for research that you'd like to do. We've funded two proposals this year. Viv and Jessica have both got resident research grants to do their work. In May of 2014, we will be giving away another tranche of money, and we plan to award up to 6 grants of $3,000 then if there are suitable proposals. We rank a small group of faculty, read the proposals, and we rank them on scientific merit, clinical relevance, quality, mental support, and what your plan is for follow-up funding to supplement the money that we give you. And when you apply for such a grant, you make an implicit commitment that you will try and seek external funds. We'd like to leverage these and see you make these multiply for the work that you're going to do. And possible sources we will talk about in a little while. Now, in the discussion that I had with some of the last month at Research Grand Rounds, some of the residents and some of the party residents said, well, we thought it was just for R2s, and then we didn't know what to do with money. So let me just address those two issues. It isn't just for R2s, it's for anybody. Obviously, we'll look hard and give preference to R2s because we'd like to see you get moving. But as far as what to do with the money, one of the things that you are really short of is time. And I know that. Time is something that you, is at a premium for you. So one of the things you can do with these funds is you can actually hire other people to help you with your research. This is a fantastic engineering school, and we have the privilege of working with some quite remarkable engineering students. The chance to work with these people is there, and there are chances which include having somebody who's going to commit 12 months to your project in the form of a capstone, and we're already doing this with one of the projects that are coming, and these people make a real difference because they are totally committed. They will not graduate unless they do a fantastic job in this project. So for you, it's like getting on a train that's moving because they are definitely going to get there. So you can hire hourly engineering people or statisticians. Statistician help is a big deal. We do not, as we discussed at boot camp last week, we don't have we have statisticians in the department, but they're 100% busy. Amy, for example, has helped many people, but she's a busy lady. And so you can use this money to go to ITHS, that is the Institute for Translational Health Sciences, and you can buy time for a statistician. That's a great thing for you to be able to do. So there are many ways, in addition to the conventional supplies and materials, cadaveric costs, publication costs, there are many ways for you to use this money. So I really urge you, we want to give you this money. We want you to use this money and to let it facilitate your career. So that's that one. Now this is brand new. None of the rest of you heard about this, but we have decided to help you travel. Now that does not mean help you to go to Hawaii on vacation, although that is possible. But you have to be a presenting first author of either a poster or a podium presentation somewhere in the continental U.S. And the maximum cost of $2,000 per trip is where we're going to start out. It's an eligible cost will include a meeting registration fee, travel, accommodation, and per diem. And you'll have to work with our accounting office to make sure you're spending it in the right way. So this is brand new. This is, all of you are eligible for this. And I know some of you like to travel. Some of you like to travel more than others, and some of you like to travel to exotic places. But this will at least get you to the east and west confines of the U.S. So we're going to put a website up. It'll be a completely web-based application. It's not up yet, but we're working on it. It'll be a rolling application. So once the money's gone, it's gone. We can't wait till the end of the year because all these things sort of pop up in an uncertain manner. It won't be a big approval process. I shall just take a look at it. Bribes will be accepted, and we'll see, get you on the move if we can. Now, briefly about grant opportunities. I want to take you to this page. This is the page on our website. Let's see if we can get there. And Teresa Bergholz, who is our compliance coordinator and who works on research opportunities and works to help people with IRBs and other things, she maintains this page. And this is a page of research grant opportunities. Looks like we're having a bit of a struggle bringing it up, but you notice that these are all resident opportunities. I'm going to go back to the slide. These are all resident opportunities from the AANA, the Orthopaedic Trauma Association. OREF just came out with their announcements. The deadline is September the 12th. There's a deadline in October for orthopedic trauma. There's a deadline in September for OREF resident grant projects. OTA, that's just gone, but keep an eye on this page because Teresa puts regular updates on there. And we've been successful in these. Many of your colleagues have had these grants, And they're good starter grants for you to locate funds. When you plan to submit a grant, on the website, on the research page, there's planning to submit a grant. You click this button and answer a few questions, and that lets us maximize our help that we can give you, because there's a lot of bureaucracy that you don't really need to get involved with, and we will help you through it. Whoops, that's a link too, so let me just go on here. Well, the internet here is a little slow and difficult, isn't it? Now, I want to finish with this one because I mentioned that I need the R2 signature. I need your signature on a confidentiality agreement which will allow you access to the Omnibus IRB application. In the past, there's been a tremendous burden of IRB applications on residents and fellows. There have been cases where, particularly fellows who are here for a brief period of time, they actually have left and gone to another institution before the IRB told them they couldn't do their study. And that's like the worst of all possible worlds. And so we've worked really, really hard to get over this. And we've had the IRB agree to a remarkable situation where we now have a blanket coverage to do any prospective review and retrospective review that meets the guidelines without going to the IRB. I am the PI of record on this, and I can designate for you to be able, just by going on research to this website, clicking there, clicking on the prospective orthopedic outcome study, and in less than 10 clicks, your title of your study, a pull-down name, and that's what I need the R2 signatures for, because you will be added to there as soon as I get that. You'll pull down the part of the body, you'll pull down primary, secondary, and tertiary sites, the number of subjects you wish to study, when you want to start, can be including today, and when you want to end, and then you're off and running. You do not need to go through the process of applying to the IRB. So the paper I showed you this morning, the paper from Farouz Badi and colleagues, that paper, as I said, could have been done on this page without any IRB whatsoever. So now this isn't everything you want to do, but for a subset of retrospective and prospective studies, it really helps you. Now, just one thing before I take your question. The retrospective study is the end date that you can review a patient ends at the day we got approval. This is a kind of an odd bureaucratic thing. It isn't rolling. So if we got approval this time last year, the last patient you can include in a retrospective study would have been May of 2012. However, they have just agreed that we can do an annual review renewal. And we're doing that now so that each year we catch up and you can take in all the patients that came in the 12 months since we had the study reviewed last time.
Yeah, just I guess that question is, what about a study that maybe was before initially with an IRB and all that needs like an annual re-up? Could you just use this instead of
You could abandon your previous protocol and take this. Now this gives you access to all the medical records, all the imaging, all the tests. If you want to do anything special, if there were some, and we also have over 40 inventories of outcome questionnaires that are included in here. The prospective one is similar. You can start the prospective today and you can carry that on for 5 years. And you can use any of these approved, validated questionnaires that are included. So I really encourage you to take a look at this because there are many questions you could answer. Could be a way of you answering important questions about surgical outcomes, and also a good way for you to get publications. Aaron.
So about the money, if they wanted to purchase software like SPSS for analysis or something like that, could they do that?
Absolutely.
And
that's very much fair game.
If they wanted to do minor upgrades to their computer, like adding additional RAM to run the processes needed, could they do that?
If it was part of a project, yes. definitely. You couldn't just apply for a grant and say, I want to upgrade my computer.
Of
You
course.
could say, I
They get
want to do
end
this project, and in doing that, I'll need to upgrade my computer, and that's fine. You can use that. People have bought computers on it. Jerry?
Just have a couple comments. Just Katie, applaud you on an incredible year. Like Dr. Kavanaugh said, she took advantage of the resources that she's very related, very bright. Grabbed her project just a fraction of what she did throughout the year. But definitely she highlighted some of the resources that are out there for doing research. The spare parts are out there. So Albert G is actually looking at taking rapid cartilage and doing countryside viability, looking at different storage conditions. Working with Aaron and Dr. Kavanaugh, in the process of doing the rapid study, there are also microstrains that have been developed, looking at tensile strength of smaller structures. That's out there, another resource for you. Another project Katie's also worked on with Dr. Kavanaugh, looking at segmentation that Nate Kollitz also worked on. So there are definitely a lot of resources out there for doing projects that are doable. Time is always a limit, always a really tough commodity for residents to find. So definitely take advantage. There are projects that you could certainly do in a very short amount of time. And I'll email you as well, Peter. There is a grant coming up. It's a ASSH fellow and resident. It's a seed grant, and the review is a 2-month process. It's August 1st. So anybody who's interested in applying for that grant, it's definitely something that's very easily accessible. It's not as competitive as some of the other grants that are out there. Something to really take a look at. And then you mentioned some of the other resident grants out there. John Cogbor actually got the AO resident trauma grant this past year. There are only 2 awarded every single year, and congratulations on John for doing that. There's definitely a lot of resources out there other than just the department grants that are out there. Take advantage of them.
All right, it's 9 o'clock. We'll stop there. Thanks so much.